So this is going to tie in nicely to Jessica's talk. Thank you very much for having me here today. I'm a urogynecologist or female pelvic medicine specialist. I work at Mount Sinai Hospital in the Division of Urogynecology. I also run a pelvic pain clinic at the Wasser Pain Center at Mount Sinai Hospital as well. So I've seen quite a few EDS patients since I started there about 9 months ago, both for pain issues as well as other kind of pelvic floor issues. So I have no disclosures to say, but the objectives of today's talk are basically to kind of look at the evidence around EDS and pelvic floor disorders, specifically looking at lower urinary tract symptoms, prolapse, and pelvic pain, which Jessica already talked a lot about. So this is an educated audience, but we know that EDS is a group of connective tissue disorders. The classification is based on symptoms, genetics, and some biochemical markers. We know what common findings include hyperextensibility, joint hypermobility, abnormal tissue fragility, and easy bruising. And there are several common gynecologic issues, specifically urinary issues, prolapse symptoms, and pain issues as well. So to start off looking at the lower urinary tract symptoms, so when I was asked to do this talk by Sandy, I started to do a literature search, and the evidence is very sparse in all of these topics, and they're all very small case series studies. So McIntosh did a study back in '95 that looked at 41 EDS female volunteers, and back then he was just looking at type 1, 2, and 3. And so they did a pelvic exam, they did urodynamic testing, and all the patients had a physio consult. Of that group, 60% had urinary incontinence, which is much higher than the general population. And 80% of the patients reported stress incontinence, which is leakage with coughing, sneezing, laughing. But despite these symptoms, all of the patients had normal urodynamic testing, which is an objective way that we measure these urinary symptoms. Another study that was done back in 2000 looked at 8 women with EDS where they did not specify the type. 4 patients had urinary incontinence. 2 of those patients had surgery for their urinary incontinence, 3 of which was for stress incontinence, and 1 patient had mixed urinary symptoms. Another study done a little bit more recently in 2007 was 30 women with benign joint hypermobility syndrome. And then they compared them to 30 control women. And they did these interviews over mail and through telephone surveys. 60% in the benign joint hypermobility group had urinary incontinence versus 30% in the control group. So when you come to my office, how do we work up patients with these problems? So we take a history, we find out what's going on. We want to know about onset, frequency, the severity of the incontinence, if there's any pain associated with voiding, if there's any urgency, any nighttime symptoms, and if you're wearing pads, and if so, how many you're going through in a 24-hour period. And then obstructive urinary symptoms, so symptoms where you feel like you're not emptying your bladder very well. And we also want to know about prolapse symptoms because sometimes they can contribute to urinary issues. We also want to know about neurologic conditions and symptoms specific to EDS patients. This is an important factor. Any other vaginal symptoms that the patient may be having, so any issues with discharge or itching. And definitely we want to know about your obstetrical history. Has the patient gone through menopause or is going through menopause, and what the hormone status is. And any other medications that the patient may be taking that can contribute to urinary issues, specifically sedatives, diuretics, any anticholinergic medications, which are drugs that are specific, that can specifically affect urinary function, and then any over-the-counter medications, which can also contribute. And then lifestyle issues, so caffeine, smoking, weight, exercise, and what they do for a living. And usually I have my patients come in and do a 48-hour urinary diary so I can see objectively what's going on throughout their day. And then on the physical exam, we always look at the height and weight, do an abdominal exam, and then a neurologic exam, specifically looking at the S2 to 4 dermatomes for the sacral nerves. And then the pelvic exam. So we have to do a careful inspection of the vulva and the urogenital epithelium, especially if they're postmenopausal. Look for prolapse signs, do a digital rectal exam to assess for the sphincter tone and perineal sensation at the same time. And often we'll get the patient to do a standing stress test to see if there's any urinary leakage in the standing position while they cough or jump. And then any studies we might do, we might take some urine, depending on what the symptoms are, just to look for blood or white blood cells or sugar or protein in the urine. If patients are having irritative voiding symptoms, we'll send for cytology. If there's any issues with bacteria in the urine or white blood cells in the urine, we'll send for a culture to rule out infection. And in our unit, we usually do uroflow testing on everybody, which means we'll get you to void into a uroflow machine to look at the volume and flow of urine. And then we'll do a residual, often by bladder scanner, to see how well you're emptying. And a normal residual volume would be less than 1/3 of the total volume, and an abnormal residual would be greater than 1/3. And then urodynamic testing, which I mentioned earlier. We'll do this in patients where we're not really sure what's going on or if there's mixed symptoms, if we're planning any form of surgery, if there are any neurogenic issues, if they have a negative standing stress test but are still saying that they have symptoms of stress incontinence, and if there's an abnormal residual volume that is elevated, which may indicate some urinary retention or what we call voiding dysfunction. So in pretty much all of the patients that come to me with EDS on the referral, I will book them for urodynamic testing so that I can try and get an objective measure of what's going on in the bladder. So in terms of treatment options, Jessica talked about the different types of urinary issues, overactive bladder, stress incontinence, mixed symptoms, and voiding dysfunction, which is urinary retention. And in EDS patients, I see all of them. And there's no formula. I think we can all agree to that. So basically, whatever the symptoms are and whatever the exam shows, and sometimes the urodynamic testing, we'll try and tailor to the patient. So if the overactive bladder is the chief issue, which is that urgency, urgent continence, frequency, nighttime peeing, which tends to be one of the more common things that I'm seeing in the EDS patients, we like to focus on behavior modification. So focusing on lifestyle and habit changes, trying to eliminate all bladder irritants. Water consumption is a big issue. A lot of the EDS patients I've been seeing also have the diagnosis of POTS, so they're drinking a lot of water. So it makes it difficult because that is definitely going to make you go pee more often. So we're having a difficult time negotiating that issue in my clinic. Otherwise, we'll talk about weight management, if there are any issues with chronic cough, trying to get that controlled. And bowel habits are really important in alleviating bladder symptoms. So if there's any issues with constipation, making sure they're on a good fiber diet and any other medications that would be required to alleviate constipation. And then the biggest thing that I refer pretty much for all my patients, but specifically for the EDS patients, is pelvic physio. They are, patients with pelvic floor symptoms, a pelvic physiotherapist is your best friend. So in terms of medical interventions for overactive bladder, there are medications. There's a host of anticholinergic medications, and there's one beta-adrenergic agonist on the market. I have used these in EDS patients, and they seem to be hit or miss. A lot of patients will come to me having already tried them, and either they had no effect or they were unable to tolerate them. Another option in refractory overactive bladder when medications are not an option is Botox injections into the bladder, which I do a lot in my clinic, but I have not done it in an EDS patient, so I'm not sure of the outcome of that would be in this patient population. Sacral neuromodulation is another option for refractory overactive bladder, which is implanting a pacemaker into the sacral third nerve to help with issues around urgency, frequency, and also urinary retention. This is only done at one hospital in Ontario, at the Toronto Western Hospital, by 2 urologists. So we kind of see where the patient is at, and if it makes sense, then we may make a referral for a test lead. In terms of stress incontinence, which is that leakage with coughing, sneezing, laughing, again, pelvic physio is the #1 thing that we recommend, especially in EDS patients. Another kind of non-invasive option is the incontinence tampon, which is seen right here. It's called the Impressa. It's been on the market in Canada for about 2 years. It's a nice device for kind of mild to moderate symptoms, and you can wear them for up to 8 to 10 hours. It's not to soak up the urine, it's to put into the vagina to provide stability to the bladder neck so that you don't leak when you increase your abdominal pressure. Another non-invasive option is an incontinence pessary, which we use a lot in our clinics. This is a picture of a couple different types of incontinence pessaries. In our clinic, we do fittings where we fit patients with these devices. They're made of silicone, they're reusable, they last for about 5 to 6 years. And, you know, again, very good for kind of mild to moderate incontinence and can be worn any way you want. I tell patients it's like a bra for your bladder. And then there are procedures. So the gold standard surgery for stress incontinence is a mid-urethral sling. And I do these a lot. But in EDS patients, this would be something that I would not recommend. Implanting a foreign material that can exacerbate any pelvic pain issues is something that is a road you do not want to go down. So this would be something that I would caution against. Other kind of less invasive procedures, there's vaginal laser, which is kind of new on the scene in the last couple of years, although it's been done in Europe and in South America for, you know, the last 10 years. I do vaginal laser, but have not done it in an EDS patient, so I'm not sure of the outcomes. The goal of laser is to increase collagen remodeling in the urogenital epithelium. So again, I'm not sure how that would work out in an EDS patient, if it would improve things. Urethral bulking is something I also do a lot in my clinic, where we inject a compound into the urethra to bulk it up. A very good option. Again, we're not implanting anything, so it's nice. And a Birch urethropexy is a bigger abdominal surgery. Again, something that I probably would recommend against in an EDS patient population. So I would tend to lean more towards the conservative options before even considering anything more invasive. Voiding dysfunction is another thing that I've been seeing a lot in our EDS patients that come to the clinic. Again, it's that inability to empty the bladder properly. Pelvic floor rehab, #1 thing again. Other things that can be done, so teaching patients how to do intermittent self-catheterization, which actually works for a lot of patients quite well. They, you know, use a little in and out catheter 2 to 3 times per day just to try and help empty their bladder more effectively and to decrease risks of infection. There's also various medications to relax the pelvic floor, the urethra, and or the bladder. There's also Botox that can be injected into the bladder, as well as the urethral sphincter for this issue, and sacral neuromodulation, which I discussed previously. And sometimes if there's any prolapse, which can be contributing to one's inability to empty the bladder, you can also try and treat that. So now moving to prolapse. Again, the evidence is quite limited. This study done in 95 looked at 107 women as just a general cohort, and they found that 39 had symptoms of hypermobility, so very nonspecific. And they found that the hypermobile patients had significantly higher rates of cystocele, rectocele, and uterine prolapse. Another study done in 96 looked at 46 EDS patients, where they didn't classify the different types, but they found the opposite and said that there was actually no correlation between joint hypermobility and vaginal prolapse. A more recent study done in 2013 looked at 60 patients, which I talked about before, with the benign joint hypermobility and the controls, and they found significantly more prolapse in the benign joint hypermobile group. And they found that those with prolapse in this group had a much greater impact on their sexual function and their defecatory function. And then a very small study that was done in 2000 looked at 8 women with EDS, and 6 patients had symptoms of prolapse. So prolapse is basically a weakening of the structures of the pelvic floor, which results in the descent of one or more of the pelvic structures. So it can be your bladder, it can be your rectum, it can be your small intestine, it can be your uterus, or it can be all of the above. This is a turtle with a little bladder prolapse here, which resulted because of a kidney stone. So it happens to all species. So why does it happen? There's a host of reasons, both non-modifiable and modifiable, but you can see here non-modifiable connective tissue disorders is right there on the risk factors. So on history, patients will say they have a bulge, they have pressure, they might have some vague voiding symptoms, they might have defecatory symptoms, they might have issues around sexual dysfunction, or they may have nothing, and I might just see it when I examine them. So we put patients down in the lithotomy position, and we look for any skin abnormalities, and we do measurements, which are called a POP-Q assessment, and then we stage their prolapse, which is stage 0 to 4. So stage 2 is kind of here, where the presenting part is just around the opening of the vagina. This is a stage 4 prolapse, where the uterus is completely everted and outside of the body. So this is the cervix right here. Then we also assess for pelvic floor strength. So we score it on an Oxford scale of 0 to 5, 5 being the strongest. We do a bimanual exam to make sure there's no fibroids or ovarian masses that could be contributing, and also a rectal exam. So in terms of treatment options, again, pelvic floor muscle training with a physio is very important. We can also use pessaries, and we can also do surgery. And in surgery, we can either do a native tissue repair, where we only use the patient's ligaments with sutures, or we can do a mesh repair. Again, in the EDS population, I would say no mesh whatsoever. Just anecdotally, in patients that I'm seeing in my clinic, I have a lot of patients with EDS who are saying that they have a sense that they have prolapse, and then when we examine, I don't find any. So that seems to be a recurring theme that we're going to have to investigate. This is a picture of all the different types of pessaries that we have in our clinic that we can use. So we really do a fitting, and we try all different shapes and sizes, and try and find one that kind of provides that good support for the patient that is completely comfortable and they don't know is in their vagina. And then EDS and pelvic pain. There is nothing in the literature on EDS patients and pelvic pain, surprisingly. So, you know, when I see these patients, we go over medical history. So what's going on? Have there been any accidents? What medications have they tried for the pain? What are they currently on? Who gave it to them? What kind of specialist? Are they on the birth control? Has that helped? Has it made it worse? Have they had any surgeries for the pain? What was the response? And then what their OB history is and what the family history is. We want to know a lot about the menstrual history. Is there any pain associated with their periods, with their urinary issues, GI issues, and talk about sexual intercourse, their current activity, their type of sexual intercourse, if they're having pain during, after, if it's superficial, deep, is there any pain with orgasm? We also want to know about various health habits, which were important also with the bladder issues, and then coping mechanisms. Who's the patient talking to about these issues? If there's a partner involved, what's their attitude towards the pain? And then, an in-depth social history about relationship status, who they're living with, are they working, are they going to school? And I give all my patients the short form McGill pain questionnaire as well. For patients with pelvic pain, talking to them throughout the exam is very important, and getting feedback and telling them what you're about to do and what you're doing it while you're doing it, it's very important. We have to observe the patients, look at what their demeanor is, how they're positioning, if they're guarding. We'll look at their back, look for any signs of scoliosis or if there's point tenderness. An abdominal exam, again, is important, looking for signs and symptoms of pain. And then the pelvic exam, sometimes we do this with a mirror so that the patient can help guide us. We want to look at the vulva. We do a single digit exam, a speculum exam, and then a psychosocial assessment. In terms of pain's not something that you can see, so findings on diagnostic imaging are often purely coincidental in pelvic pain patients. We will send for an ultrasound if we think there's something gynecological. And MRI, CTC, PET scans are reserved for special investigations, and really have no role in routine diagnosis. And diagnostic laparoscopy, we only do if other therapies have failed. It's the only feasible or reliable way to diagnose endometriosis and adhesions, but it's surgery, so it's not without risk. I recently had a patient tell me 2 weeks ago that EDS patients are known to have endometriosis. There's that association, and I don't know that that's necessarily true. I think what often happens is that EDS patients present with pelvic pain, and their family doctors or their gynecologists don't know how to deal with that, so they stamp them with endometriosis. So I don't know that there's necessarily that correlation that exists. Yeah. So there's a host of different pain syndromes that can exist: bladder pain syndrome, vulvodynia, endometriosis, myofascial pelvic pain, and the GI conditions. The myofascial pelvic pain seems to be the most common one that I'm seeing in this group. Physiotherapy is the most important therapy. We'll often try neuropathic medications, so amitriptyline, gabapentin, or Lyrica. I tend to try intravaginal diazepam, although the results are very variable. And then sometimes we'll do injections with local anesthetic and steroid or Botox. And this is basically what we just talked about. But generally for EDS and all of these issues, the number one things are lifestyle and pelvic physio. And, when you're talking about medical interventions, consider them very carefully with your physician, and, do it step by step and look at the results after each treatment. And that's it. Thank you.